So good afternoon, everyone. Thank you very much for joining us today. Here with us is Dr. Goldenberg, and to join us soon, hopefully, is going to be Dr. Langman. I'm going to start by talking a little bit about colon cancer awareness. This is the month of, well, was March, as a matter of fact, and we're closing that month with this webinar. It's very important to know that screening for colon cancer can truly save lives, and that's what we are going to be talking about today. We're going to be discussing how you can save your life by doing good screening. So I see that Dr. Langman is with us now. So thank you so much. I know that you were probably rushing to get to us. So I appreciate very much that you made it here. So Dr. Goldenberg, would you like to start? Would you like to tell us like who you are, where you work, a little bit about yourself? How did you get into this field?
Hi, everybody. I'm Dr. Goldenberg. I work with Dr. Langman. He just joined us in the meeting. At the bottom of your screen, we're both located at Digestive Disease Associates of Rockland in Pomona on Route 974, Route 45, and we have our website listed there. I've been in practice for 33 years, enjoy gastroenterology, and we do a lot of in-office endoscopy, as well as the hospitals, both Nyack and Good Sam. And we're here today to talk about colon cancer awareness. And it's not only in the month of March, but for us, it's every month of the year. And it's an important item to review and to discuss. So we'd like to proceed on that note, but Dr. Langman, why don't you just introduce yourself and we'll proceed along.
Yeah, hi, thanks for waiting. I was finishing up a colonoscopy, but yeah, I mean, I work over with Dr. Goldenberg in our office, doing all sorts of digestive diseases, liver, colon, but especially looking out for, colon cancer, and excited to be here with you guys today to go through some of it and answer some questions and maybe clear up some things that maybe aren't so clear.
All right, so moving along, the most important fact is that screening does save lives, and all we have to do is take a look. And there are many different ways to do that. Some are non-invasive, and obviously colonoscopy being an invasive tool, it's done under sedation, and Dr. Langman will talk a little bit more about that in a moment. The colon cancer statistics and why it's so important. It is the third most common cause of death in the United States, and there's about 55,000 deaths per year from the colon cancer, with 140,000 new cases diagnosed each year. And in New York State alone, 10,000 people are diagnosed and 3,500 die each year. And by doing colonoscopy and screening, we certainly can lower that number substantially. The colon itself is about 4, 5, or even 6 feet long. Some people have longer or shorter colons. It all depends. The main function in the colon is to absorb water, and that's predominantly on the right side of the colon. On the left side, that's where the solid waste is expelled and pushed out through the anal opening. Certain risk factors are important to know where you stand as far as when to get the colonoscopy. One important item is the family history, especially with first or even second degree relatives. Aunts and uncles also count. Family history of colon polyps would increase your risk. But if you have 2 family first degree relatives, your risk is at least 2 or even 3 times higher than the average population without any family history. Other important items include Crohn's disease, ulcerative colitis, familial adenomatous polyposis. Those patients are usually screened quite young. Anyone over the age of 50, and now it's moved back to 45, are certainly at risk. Other risk factors that we look at are obesity, smoking, and drinking heavily can account for an increased risk. What type of symptoms do patients have? A lot of times they're asymptomatic. You may have nothing, especially if the lesion or the polyp, which is felt to be a precursor, is found in the right colon. Other symptoms include diarrhea, constipation, narrow stools, an urge to move your bowel, and having no relief after you go. Rectal bleeding certainly is a red flag. with blood in the stool or even a dark brown stool, because it could be microscopic bleeding. Abdominal cramping with pain. And if you have any profound weakness, you might be anemic without obvious bleeding and certainly can have something going on. Fatigue or any unexplained weight loss. Certain things that might be protective include a low-fat, high-fiber diet, a daily aspirin, whether it be an 81 milligram dose or a regular 325 milligram dose, has been shown to decrease polyp formation and even colon cancer. Obviously, good general health, exercise, taking your vitamins, eating well, and the most important aspect is screening. So what do we do about screening? These are just some general rules of thumb about fiber and eating well. With a high fiber diet, having 20 to 30 grams of fiber in your diet is felt to be a good way to go and improve your bowel evacuation. Dr. Langman's going to take over from here and talk about what happens in colon cancer and what do we do about screening. So Yaron, why don't you take over?
All right. Thanks, Dr. Goldenberg, for that initial introduction. So what's the point of screening? So the point of screening is to find these precancerous lesions that can and remove them and prevent cancer from developing, or also finding cancer early when it can be treated adequately before it spreads and becomes more difficult to manage. So what in colonoscopy or in colon cancer screening, what are we looking for? What are these predisposing precancerous lesions? So if you look at the screen, a normal, healthy, clean colon is what we see on the left. So when we're doing colonoscopies, this is what we love to see. So a normal colon, you can see the normal blood vessels. This person did a really good job with their colon prep. But polyps can start to grow, and they can look differently. And there's a few different types of polyps, but the typical ones that we see are called adenomas, which are precancerous kind of polyps. And you can see the picture in the middle of the screen. This is an adenoma, or a precancerous benign polyp on a stalk. If it's left in and not removed over a slow period of time, over a few years, it can then grow into what we see on the right screen, on the right picture over here, or a colon cancer. At that point, and maybe it's early enough it can be removed surgically, but maybe it's spread, and we want to find and prevent these before they develop. Andy, I think you're running the slideshow, right? Go to the next slide.
Okay, yeah, just the down arrow, that's fine.
Okay, so when we talk about colon cancer screening, we're talking about tests that can identify these polyps or early cancers before they become a problem. And there's a lot of different tests available. So I'm sure most people have heard of colonoscopy. We're going to talk a lot about that today, but there are other tests available. Most recently, all the gastroenterology or GI different groups, the American College of Gastroenterology, the American Gastrology Association, all got together and came up with a colon cancer screening guidelines. And they divided into 3 different tiers. They said the first tier is what we recommend, has the best evidence. If you can't get one of those tests for some reason, then they would recommend moving down to tier 2. So the first is tier 1. Tier 1, they recommend something called FIT testing, which is fecal immunohistochemical testing. And this tests for trace blood in the stool. So some of you may have had that or seen it. Basically, it takes a small little stool sample and they check for microscopic amounts of blood. It's not invasive. It does have to be done frequently every year to try to catch these things when they're small or early. Colonoscopy is considered the gold standard because you go in there, you find these polyps and remove them in one step. It is the most sensitive for finding these polyps because sometimes small polyps aren't bleeding or causing any blood loss. And again, we'll talk about each of these tests in more detail in the next few slides. In tier 2, these are tests that are mostly just looking for signs of polyps. If they're there, then you would go and do the colonoscopy. So a CT colonography is a CT scan or CAT scan where you can see the inside of the colon. And it still requires a colon prep, so you still have to clean out, and they have to put air into the colon during the test, so it's uncomfortable, but it's not invasive. You don't need sedation. There's a newer modality around which has gained a lot of traction called Cologuard fecal DNA testing, where they take a stool sample and they check for traces of abnormal DNA in the stool along with traces of blood. And then sigmoidoscopy is like a limited colonoscopy just to the left side. And that has been shown to be very effective, but it misses anything on the right side of the colon, which unfortunately is a lot of colon cancers. And then tier 3 is made tier 3 because they're newer technology. It's not widely available. This is called video capsule colonography, and we've done a handful in our office. But what you do is you swallow a video pill, and it takes video of the colon, and it's good for people that can't have procedures for some reason. They're on blood thinners. There's reasons they can't have it, and it takes really nice pictures of the colon. And we'll talk about that again in a few slides. Okay, Andy, next slide. Okay, so we talked a little bit about the FIT testing. Again, this tests for trace blood. This is a newer version of the old guaiac testing, which many doctors still have in their offices, where they take a little stool and put some drops of water on it. This is a better test than this plain stool guaiac. Most of the time nowadays, this is done through a lab like Quest or LabCorp. And again, this is a really sensitive test for trace blood. If you're going to do this as your screening modality, you want to do it every year. So at least every year. So colonoscopy, that's a picture of a colonoscope, the camera that we use to look inside the colon. What's great about this is that it detects and removes the polyps in one step. It's the only way to do that. So you find a polyp, and we see polyps in about 30 to 40% of people. So that's what we expect to see is benign polyps, precancerous polyps, about 30 to 40% of people. The colon has to be cleaned out well, and that really is important for picking up picking up polyps. If it's normal without any polyps, we do this every 10 years. If there are polyps, 3 to 5 years, depending on the size and the number of polyps. And they're a safe test. It takes about 15 minutes. We do it in the office, usually with sedation. Very small risks of things like bleeding or tearing, but that occurs about 1 in every 1,000 or whatever, even less than that. All right, Andy, next. Sigmoidoscopy, like I said, is limited to the left side. So it's not going to pick up tumors in the middle of the colon. You see that transverse colon on the top or on the right side of the colon. They recommend doing this more frequently because we're only doing one side of the colon. So we don't do this much anymore for screening. Older technology is like something called a barium enema, where they put contrast or dye into the rectum and can look at the colon that way. This is good for picking up big polyps or tumors. It's still on the list of ways to look at the colon. But again, if it's positive, it's not as sensitive, then you have to do it every 5 years. Okay. So we talked a bit about that fecal DNA testing. It's really gotten, you see advertisements on TV. A lot of doctors are doing it with their patients. And it's a really good test for people that, again, can't get colonoscopies for some reason or are really averse to getting a colonoscopy. It does have a fairly high false positive note. So people come into our office very anxious because it was positive. They're convinced they have colon cancer. And about 12% of people have false positives. And then if you look at that graph on the bottom, you'll see that it also is not as sensitive for picking up even big polyps. So, if you look at the bottom of that screen there, the FIT testing is the stool blood test. We talked about the Cologuard is a little bit better, and about 30 to, it picks up about 40% of large polyps compared to about 80 to 90% in a colonoscopy. Okay, next. We talked about that virtual colonoscopy or CT colonography. And this is a CT scan. You still have to do a really thorough prep, which is most people's reason for not wanting to get a colonoscopy. But if it's done well, you can see that you can get nice pictures. If you don't clean out well, then stool can be mistaken for polyps. So it's not done as widely as it was initially. And then this is a picture from a capsule colon. This is the video capsule that you swallow. It's a bit difficult to do because the prep, you have to do prep while you're doing it. So you do the prep the night before, you come to the office, you swallow the pill, you take some medications to kind of push things forward, and you do more prep during the day as the capsule's in you. So it's very effective. It's nice. It's only limited availability, and it's probably going to become more available, say, in the next 10 years. But it's not a simple, easy test to take. Next. So, Ed, do you want to take over here, or do you want me to do?
Sure.
Okay.
So when do we start screening for colon cancer and polyps? And the recommendation has been 50 as the age. The Black population was 45, and now the pendulum is swinging to age 45 for all of us, white or Black. And it's important to get screened early because we're seeing polyps and bigger polyps in younger individuals, and we just don't know what causes this, but they're there and we need to check. The other thing is 10 years, if someone in the family has colon polyps or cancer, we usually like to look 10 years prior to the onset. So if someone had colon cancer at age, let's say 55, we're going to look at 55, 45. If it was 50, we'd look at age 40. So we usually back it up 10 years. In people with a higher risk, like ulcerative colitis or Crohn's disease, we start after 8 years of disease duration. The following intervals should be followed for different screening modalities. We do the FIT test annually or colonoscopy every 10 years, as long as your baseline colonoscopy was clear. Makes us a little nervous to say 10 years, but that's what's recommended. We often are saying 7 to 10 years for our patients. And we do the DNA or Cologuard testing every 3 years if that's the way the patient is going to be followed over time. Most of us are recommending complete colonoscopy rather than flexible sigmoidoscopy because, like Yaron said, we are not able to clear the right colon. And then the other options were mentioned already, and those are mentioned every 5 years. So it's important to know your risk. Are you otherwise healthy? Do you have family history? Do you have Crohn's or ulcerative colitis or familial adenomatous polyposis that increases your risk? Certainly increasing age is important. And then the other factors, this is sort of just a simple review there. Being overweight and obese increases your risk, not only for colon cancer, but other cancers and other cardiovascular issues. So being physically active, staying on a low-fat, high-fiber diet, avoid smoking and alcohol are all important aspects that you can sort of control on your own to lower your risk. But the most important thing is to get screened because colon cancer can be prevented. It's certainly curable and treatable, but if you know your risk, know where you stand and get at least a study done. If you choose not to have an invasive procedure like a colonoscopy, do the non-invasive test, because if that test is positive, then you should have a colonoscopy. And with that in mind, I think that's where we're going to end here, and certainly would be happy to discuss and answer any questions.
Thank you so much, Dr. Goldenberg and Dr. Langman. And just a reminder to all of our attendees, please write your questions using the chat box. I'll be happy to read your questions to the doctors. So now that we're talking about this, a few questions popped in my mind, and I think you went over that already, but I would like for you to please repeat it so that it's clear for people. First of all, when do we need to start screening for colon cancer?
Yeah, I'll take that. So for average risk people, so people without any family history, without any other diseases that increase your risk, it's a bit of a moving target. So we're starting to push that to 45 where it used to be 50. And all the national societies are starting to move in that direction. So I would start having that discussion with your doctor, as you approach 45, and to consider it, but certainly by the age of 50.
Okay, now it has to be that you have family history of colon cancer, or would any cancer put you at risk for colon cancer?
So that's a good question. So certainly there are certain syndromes that increase your risks. For colon cancer in particular, for colonoscopy, colon cancer or advanced colon polyps is really the most important. If there's a specific syndrome or genetic mutation that they've picked up, then maybe other cancers as well. But just like if somebody has breast cancer in the family, no, it doesn't mean you have to do an early colonoscopy.
Okay.
And I might add one thing about breast cancer. Those patients who have a history of breast cancer, there's a 10% higher incidence of colon polyps and colon cancer in those individuals. And my teaching, at least at Mount Sinai in Manhattan, where I was trained, was that all breast cancer patients should have at least a colonoscopy, certainly by age 45.
Mm-hmm.
Enter that population because they are at a higher risk. But family history of colon cancer certainly is the most significant factor.
Excellent. And Dr. Langman, you mentioned genetic mutation. So how do we know that we have that genetic mutation?
Yeah, so that's a really good question. You're not going to know that routinely. Maybe down the road as people get some of these online, genetic testing or testing for other reasons. Usually it comes up when you're being tested for something else, like somebody in the family has cancer, you have another kind of cancer, and they pick up these genetic mutations. But it's not a routine thing that anybody's doing, but there are some available, like 23andMe. You can do, some people come in with abnormal findings from that.
Mm-hmm. And now Jill is sending some questions here. Let me see. She says, do you recommend genetic tests to detect the possibility of colon cancer? Father died of colon cancer at 61, third colonoscopy, had first polyp.
Right. Yeah, so the answer is for that, no. I think that at the age of 61, that's not considered a high suspicious age for a genetic mutation. If you're young and if somebody's younger than 50 or has certain features of their colon cancer that are increased risk, those are people that should definitely be tested. Sometimes oncologists now more frequently are doing some genetic testing or recommending it as it becomes more common, but probably not in that scenario.
Mm-hmm. And Althea says it will be helpful to see what a 20-30 grams fiber diet looks like. How much of whole grains, vegetables, and fruits do you need each day? What will a day's meal plan look like? And I love this question because as a dietitian, we're always thinking about prevention and good diet. So maybe it's time to talk about what's a proper diet to prevent colon cancer and then answer Althea's question.
Well,
Yeah,
interestingly, I'll take that, Jerome.
Yeah,
Eating a high fiber, low fat diet, we feel is important. There were some good observational studies where actually in Japan, initially people were eating cheeseburger and Big Macs and didn't get colon cancer until they came to the United States. Because when they were in Japan or in those areas where you're having fish and eating vegetables, they didn't develop that. But that kind of data didn't pan out so much. So the thinking is that the more fiber, the low fat, it seems to help. And when you look at total quantity of fiber, like 20 to 30 grams a day, a lot of times you can look at the side packets of every food item that you have. If you look at the cereal box, they'll have grams of fiber listed. And certain ones like Raisin Bran, 9 grams. Fiber One cereal for breakfast, 14 grams. Those are almost putting you halfway there. An apple, a piece of fruit is going to, or a salad, give you 2 to 3 grams. So if you add up all the items in your daily diet, the more grains and fiber substances in fruits and vegetables, that's the type of diet that you're looking at to maximize your fiber intake.
Yes, and
Dr.
just to
Langman,
add,
you want to add anything to that?
Oh, I agree. That's good.
Yeah, and just to add a little bit of that, usually I don't know how many people are familiar with MyPlate, but MyPlate is just like a graphic of what the plate should look like. So half of the plate should always have like fresh fruits and vegetables. Then a quarter of the plate should have whole grains like brown rice, brown pasta, whole wheat bread, and then only make a small portion of low fat meats. And usually when you eat like that 3 times a day, definitely you get to your 30 or more grams of fiber a day. Just saying that as a dietitian, Okay, here is another question. Mother, 2-time survivor of breast cancer. Not sure what that means.
She had breast cancer twice.
Oh, yes, but I don't know what the question is. Mother, 2-time survivor of breast cancer. But well, you were talking about the relationship between breast cancer and colon cancer and how if you have breast cancer, it raises 10% the risk.
Well, if you have one cancer, you're at risk for other cancers. And there is an association between breast cancer and a higher incidence of colon polyps or cancer. And that number, at least when I was trained, was at least 10%. So we feel that those patients who've had a breast cancer, and for this particular patient, breast cancer twice, highly recommend that the patient be speaking with their doctor about having a test done. If it's not colonoscopy, then at least a FIT test or a Cologuard to sort of examine where you stand. And if it's positive, then you move on to colonoscopy. But it's important to get screened.
And Dr. Langman, you were talking about adenomas. So can you explain a little bit further what adenomas are and if all the adenomas actually turn into cancer?
Right. So adenomas are polyps or growths in the colon, which have precancerous potential. So will they all turn into cancer? No. I can't give you a number. I don't know, maybe Andy, you can. What percentage, if left in place, would become cancer? But it's probably in the order of, say, 15 to 20% is my guess, 10 to 20%, maybe a little bit lower. There are other kinds of precancerous polyps as well, something called the sessile serrated polyp. These are slow growing growths that over time develop more mutations and can grow into cancer.
Mm-hmm. Okay, and let me ask you something, because a lot of people might be wondering, like all these screening tests, are they covered by insurance?
Absolutely. So colon cancer screening is all covered by insurance. After the Obamacare rules, a while ago, a straight colonoscopy now has no copay. If there's biopsies or things are removed, that changes it a little bit. Although they've been working on getting rid of those loopholes, but it's completely covered by every insurance.
Mm-hmm.
I might also add one thing: the Cologuard. It's covered by Medicare, up to, I believe, age 83 or 85. So if let's say you're healthy at that age and you still want to have yourself screened, there's an age cutoff, and I believe if you don't meet their criteria, it's probably about $600 to get it done, something like that.
Yeah, I was just going to ask about that. What if you don't have insurance? Obviously, if you don't have insurance, you're still going to get sick. So how do you go about that? How do you get a screening if you don't have insurance?
Well,
so there are certainly programs. I don't know, Andy, you want to talk about that?
No, I guess you'd have to go to try to apply for Medicaid or get some sort of assistance or pay out of pocket in a payment plan.
Right. So the American Cancer Society has programs where they do reach out and can help cover colon cancer screening. NIAC had been in cooperation, had a colon cancer screening program through the breast center, the Women's Health, the breast center. And I believe that's still active, and that can certainly be checked into. But there are certainly programs and societies that make colon cancer screening available for people without insurance.
Yes, now that you mention it, it's true what you just said. So the breast center or breast cancer center in NIAC, they have a special program for cancer screening. So if you don't have insurance, there is some paperwork that you need to submit for what they call charity care, and then you can get very discounted, like from 80 to 100% discount on screening tests, not just for colon, but breast cancer or other types of cancer.
And it's for men as well as women too.
Absolutely, men and women. And talking about men, especially men, I feel that they have fear of having colonoscopy done. Like, how do you convince the men in your house? Like, what can I tell the men in my house? Like, go and have a colonoscopy done. It's not gonna be bad, and I'm a Latina, especially Latinos are like, nobody's gonna go up there. How do we convince them? Help me convince them. I know that a lot of us wonder that.
Sedated. They'll be sedated. They won't feel anything. They will have the best sleep of their life because they're given propofol intravenously. So the fear factor really goes away. And when patients are treated like that, they wake up and they're asking, have you started yet? So, and we're done. So they just have no recollection of the procedure. So I think if they are comforted knowing they're going to be sedated and feel nothing, that's the way to talk about it. The prep is the worst part, but it's certainly doable. And we can give small volume preps with Clenpick. It's only 2 little small bottles of 5 ounces twice with a lot of water, and that should be the easiest prep one can take. So we try to minimize it and make it as pleasant an experience as possible.
Dr. Langman, how do you convince your patients?
Yeah, no, I think that that's exactly it. Nowadays with the anesthesia, it's such a comfortable experience. Back before where you had, it was uncomfortable and you really had to be awake and feel it. That doesn't exist anymore. So the sedation is really, really a comfortable thing. The worst part is the prep, and you have to clean out. And truthfully, the standard prep that we often use is just Miralax and Gatorade. It's just like drinking Gatorade. It doesn't taste bad. Some of these smaller prescription volume preps are available if the volume is, like Dr. Goldenberg said, is the issue. And then I would just remind them, look, it's all about we're trying to save lives and trying to, you don't want this to show up in 5 years down the road when it's a cancer that can't be removed. You do it now, it's not uncomfortable, and just get it done.
Mm-hmm. Now, we have a question from Patrick. Can you advise on the need to take an aspirin as a precaution?
That's a really good question. There is some evidence that aspirin can help limit polyp growth or help prevent polyps. It's not great evidence. And so really it's not routinely recommended. In people that have polyp issues, sometimes we recommend aspirin, but I think that's something that there's more to follow. And I think that over the next few years, we'll probably have more data and information about how well that does help. But preliminarily, yes, that's a great question. It does seem to help minimize polyp growth or limit polyps and may improve. So people are often on aspirin for their heart or for other reasons, and that's another nice side effect. Just for colon cancer screening, I probably would not recommend starting it. Andy, I don't know.
Also doesn't give it approval yet as a indicator, so it's really
Right.
patient to patient, doctor to doctor, depending on your risk. So it's not an automatic for everybody across the board.
Yeah.
And on the same line, you also mentioned low vitamin D being a risk factor. Do you want to expand on that?
One? Yeah.
Yeah, sure. I mean, there again, there's also a bit of a early research, but low vitamin D levels seem to correlate with developing colon cancer, and vitamin D supplementation may help minimize that risk. The data has been mixed, and the studies aren't great right now, but I think it's also another thing that's brewing. Vitamin D, low vitamin D levels are linked to a bunch of different diseases. So I think it certainly, pays to get your vitamin D level checked to make sure you're not deficient.
Okay. Any other, I don't know, precautions that we can take in order to avoid or at least delay the onset of colon cancer?
Say you get screened. I mean, it's not like you have to do anything in particular. You just have to get it done. It's like going to get any additional. You go for a routine mammogram, GYN exam, prostate exam. As we all get older, there's certain screening tests that we feel are important to minimize your risk of a cancer diagnosis. And for us, it's colonoscopy is the gold standard.
Mm-hmm.
And then also, emphasizing healthy diet and lifestyle. So, eating a high fiber, low fat diet, not eating a lot of processed meats, exercising, all those things are really important. They're not going to, replace screening or replace colonoscopy, but they probably will lower your risks.
Mm-hmm. And you also mentioned smoking to be a risk factor. What about cannabis use? And especially now that, it's getting approved everywhere, and, people can be using it more left and right.
To be seen. That's an interesting question.
Yeah, we don't have the data on that yet. Not so sure it's going to play out and increase your risk.
Mm-hmm.
I would doubt it.
And I think that there is something that I probably missed or hasn't been mentioned yet, which is constipation. I feel that constipation is such a popular thing, like a lot of people suffer from constipation. Is that something that we should pay more attention to, or, is that normal as many people think?
It's normal to have that. It certainly has no bearing on your risk. It's not considered a risk factor for colon cancer or polyps. But people have variable bowel movements and go differently from day to day. Some have irritable bowel and constipation, some have diarrhea or alternate between the two. and it's felt to be completely normal. But if it's new onset constipation, definitely get checked, because you never know unless you look. That I
Mhm.
believe is an important message. You never know unless you look. So
Mhm.
that's important.
So
Anything like a recent change in your pattern is important.
right. Yeah,
Yeah.
that's what I was gonna say. So if you have been constipated all your life, that's probably your normal for you. But
Correct.
if you see any changes in your bowel movements, then you should alert yourself and go get checked.
Absolutely.
Excellent. Okay, I don't know if any of our attendees would like to write any more questions. Any other advice, Dr. Goldenberg, that you would like to give to people to encourage them to go and have a colonoscopy done?
Nothing other than what we've mentioned. I think if at least do a screening test rather than do nothing, because doing an exam at least does give you some idea on where you stand. The gold standard is colonoscopy, but like we've said before, there are non-invasive ways to take care of the problem, and those are certainly acceptable. Not the best, but if it's positive, then you move on to the next level, which would be colonoscopy.
Mhm.
So
And
please get checked.
right, something that we haven't touched on, and I think that is important for people to know, is if you get diagnosed with colon cancer, how is that going to change your life? Because people might be thinking like, it will happen, I have to die of something, how people think. So I would like to face reality a little bit here and say, okay, you decide not to get a screen, and now you have colon cancer. How is that going to change your life?
Yeah, I mean, look, I think that it really depends on how early it's diagnosed. Generally, even if it's early, I mean, it does mean surgery. Sometimes that means a colostomy. Oftentimes it doesn't. Now, as far as if it's advanced, if it's grown too far and you need chemotherapy and it's no longer an operable, it's a hard chemotherapy now. Advanced colon cancer, they have newer chemotherapies and it can be very responsive, but it's not always responsive. And yeah, I mean, you can die, and you can die at a young age. It's always tragic when we see somebody who's 52 and didn't get a colonoscopy, diagnosed with metastatic colon cancer unnecessarily. And that's really what we want to avoid.
Mm-hmm. Do you have any signs or symptoms of early cancer that we should be aware of?
Yeah, so we had a slide earlier that showed some signs and symptoms of colon cancer, but unfortunately, often the signs and symptoms don't show up until things are advanced. Sometimes early colon cancer can give bleeding or blockage or change in bowel movements, but often it doesn't. And so really the only way to really get these things early or avoid them is to do routine screening.
Right, it's one of those silent killers, as we call them.
Exactly.
Yeah, I might add, if the colon cancer is on the right side of the colon, you will be asymptomatic. You will feel nothing. If it's on the left side, you might see some fresh blood or constipation as an outlet problem where the stool cannot exit the body. So if it's left-sided, maybe a little earlier detection, but the right side, you may have no symptoms whatsoever.
That's interesting. Yes.
Yeah.
And we have one more question. Is there an age limit beyond which colonoscopy? Is there an age limit beyond which colonoscopy is not recommended or not paid by Medicare?
So we often will think that screening should stop at age 75. That's where we start to talk about this could be your last checkup. But lots of patients are healthy and doing well into their 80s or even 90s. So I think it's an individual discussion that one should have with their primary doc or the gastroenterologist who they're seeing on when to stop and what their likelihood of having a problem is. And then sometimes I've seen colonoscopy patients and they say, I don't want to do that colonoscopy anymore. Let me do the Cologuard. The Cologuard will be covered at age 80. It's non-invasive. If it's negative, I think I'm pretty good. If it's positive, well, then we go on and move to the colonoscopy exam. So that's how I handle the aging factor.
Right. Well, what I think is, who doesn't want to live to 100, right? And
right.
In order to be able to do that, you want to live to 100, but you want to live to a healthy 100. So screening is definitely essential for colon, breast, as Dr. Goldenberg was saying, you know, any type of screening is really important. So, you know, this is again, a call for all of our attendees and your family members and your friends and everyone. If you haven't had a colonoscopy yet, you're over the age of 45, you have risk factors, which we have talked about here. You know, if you have family members who have had some type of cancer, please reach out to your doctor, get your colonoscopy done, screen. I'm telling you, it's super important to do that. Don't wait, because it could be too late. Correct?
All right, yeah, and you know, we look forward to meeting some of you, and if there's any questions, you know, reach out to us in the office, and if you have concerns, you know, individual concerns, we're always happy to address those and deal with those on a case-to-case basis.
Right, and I think you had your phone number on the first slide, but
Yep.
can you just say it again loud? I'm gonna write it
Sure.
in the chat so that people, 845.
845-354-3700. We're exit 12 off the Palisades in Pomona,
Mhm.
and we'd be happy to see anybody, your family, friends, relatives, anyone.
Yes, and nowadays I think scheduling colonoscopies can be really easy. You don't have to go to a hospital or anything like that. It can be, you know,
Nope.
in and out, in the office.
Yep.
You don't feel a thing.
That's
You
right.
don't have to have your macho ego hurt or anything like that, you know. So
Absolutely.
very good. Okay, I don't think we have any more questions. People have started to say thank you, great information. My time also to say thank you to Dr. Goldenberg and Dr. Langman for being here with us and sharing this important information. Again, I can't stress enough the importance of screening. You know, I've lived it myself with family members and so forth, and it's very important that you guys do it. And I don't know if you have any further thoughts or last words.
I just want to thank you, Sandra, for leading the discussion and having us meet you and have an opportunity and take the time to talk about an important subject.
Yeah, thank you as
you.
well.
Sandra.
Thank you. I'm sure it will not be the last time. It's so much to talk about gastrointestinal diseases that please come back anytime. Let me know, because, you know, I would like to know about irritable bowel syndrome and polyps. And now all these
Sure.
things that you mentioned, I know that a lot of them are very popular and people have a lot of questions about that. So without further ado, you are invited to join us next week for a 9 to 0 nutrition webinar. It's going to be about how to lose weight eating 6 meals per day. We'll see about that. And then, you know, I sent the agenda with all of our April programming yesterday. I hope that you can join us. Thank you for all your questions and for your time, Dr. Goldenberg, Dr. Langman. Thank you so much. It was an honor to have you with us today. Thank you for your time.
Again.
And
Thank you.
we'll see you next week.
Bye.
Bye-bye.
Okay.